Hey guys, Sue Falsone here, and I'm in Phoenix, Arizona, in my home office. My wiener dog named Richard is laying on my lap. I cannot promise we will get through an hour of a discussion without him barking. It's a total crapshoot with dachshunds. I am super disappointed that I can't be in Orlando with all of you. I was really looking forward to hanging out with all of you and learning together as we should be. These are really obviously unfortunate and crazy circumstances, and I certainly hope that everybody is safe and healthy and doing well. Definitely grateful for innovative opportunities to provide learning for people, and so it's great that we have this platform to be able to do it virtually. So super honored and was really excited that we're able to move ahead with the conference, maybe not in the way that we initially wanted, but kind of in a different way. So anyway, I'm really excited to talk with you guys about this topic today. What we're going to talk about is the nervous system. What do you really need to know? And this talk was really based off of chapter 7 of my book, Bridging the Gap from Rehab to Performance. And we're going to talk about the system of the book a little bit and sort of where the stuff fits in. But after this sort of 45 minutes to an hour, what I'm hoping to do is really present a case for you that we don't train the musculoskeletal system, we train the neuromusculoskeletal system. And the more we understand the nervous system and how the nervous system responds and works, we can improve our programming across the board. And that's really what it's all about. So love this topic. Super excited to talk about it with you guys. Let's see. My financial disclosures are as follows. I'm the owner of Structure and Function Education, which is an online education company as well as an in-person education company. Performance Council member for Nike, as well as have several products on target publications. So those are my disclosures. This really summarizes my book, Bridging the Gap from Rehab to Performance, in one slide. And I don't want to spend a ton of time on it, but I do want to go through just sort of the fundamentals of the continuum as we progress a client or a patient. And just know that if I say client or athlete or patient or human, right, they're all sort of the same in my mind, because we know that there's not one spot where rehab ends and performance begins. So there is sort of a continuum of this entire thing. And I think it's important that we understand that there is a time and a place for everything. And yet at certain times during the rehabilitation process into the performance process, as someone is returning to the field, that certain things take precedence. And so on the left down here, we start with the pain generator. And for me, that's really sort of the source of someone's pain. I think it's very important early on in the process to make sure that we accurately identify the pain generator. Meaning, do we understand the tissue that is the issue? And if we can't identify a tissue that is the issue, and maybe somebody is in a different kind of state of pain where there isn't an inflammatory nociceptive pain generator, then we need to know that too and understand that, because that's a completely different patient and a completely different plan that we have to create. So that's what I mean by pain generators, really identifying the source of someone's pain. When I talk about the motion segment, for me, that's really about identifying the cause of somebody's pain. How is the system kinetic linking or not kinetic linking? What's the kinematic sequence looking like? How is the ankle affecting the shoulder? What could be possibly going on there? So again, it's not just about identifying the source of someone's pain, but also identifying the cause of someone's pain. As we move down and I don't like to call it a continuum, it's really more of an organizational system. So as we kind of move down here into the psychomotor control portion of it, this is the right muscle firing at the right time. Is the agonist being the agonist? Is the synergist being the synergist? Is the stabilizer being the stabilizer? And when a stabilizer has to become a prime mover, the body gets angry. If the prime mover has to become a stabilizer, that doesn't work either, right? Certain muscles have certain functions at certain times in a motor pattern. So we have to make sure that the right muscle is doing the right thing at the right time. That's what psychomotor control is about. And a lot of times that happens early on in the rehab process as people are very specifically focusing on muscle activation and those sorts of things. That's really sort of where my muscle activation programming kind of falls into play, as the psychomotor control category. As we move into somatosensory control, This for me really is all things nervous system related. There is a time and a place to work on someone's balance, to work on someone's postural reflexes and control, and those sorts of things. And that's where we're going to spend our time today, is in that somatosensory area. Fundamental performance is about foundational strength. And if you're more of a rehab specialist, that would be considering someone to have 5 out of 5 fundamental strength. Is somebody strong enough to do a movement, and are they able to express that strength in the form of power? So are they able to move with speed, and be able to tolerate that? Can their joints and their tissues tolerate that? So that's really where fundamental performance is. It's all about foundational strength training as well as power training. Then as we move down into fundamental advancement, for me, this is where we really apply those things to foundational athletic movement. So can somebody accelerate? Do they need absolute speed? Can they decelerate? Can they get into an athletic-based stance? Are they able to shuffle, crossover, drop step, open step, all of those things that sort of make up multi-directional movement? Can they jump? Can they land? And then can they transition from any one of those movements that I said to any other movement? Because that's how athletic movement is formulated, right? It's not just about being able to perform the movement, but can someone transition from one posture to the next? So that's all the fundamental advancement category. And then finally, in the advanced performance category, that's really about, are we dealing with a baseball player or a football player or a soccer player or a tennis player? That's where it matters, not only their sport, but their position, right? We know just because somebody plays football, the physical demands of a quarterback are completely different than the physical demands of the offensive line. And so we need to be able to understand that each sport and each position within that sport have very different demands. And how do we apply everything that we talked about to them as a very, very specific athlete? So down there on the left, again, we have things that are very diagnosis specific. It does matter if someone has a herniated disc or some type of stenosis in their spine, because generally I'm going to treat those two diagnoses very, very differently. And my interventions also may be extremely selective based on the tissue and the stage of healing that tissue is in. Depends on the type of attention that it requires. So it's very, very diagnosis specific. Whereas we kind of get into the middle here, things are super diagnosis inclusive, meaning everybody gets core stability, right? It doesn't matter if they have a herniated disc or a spondylolisthesis or a stenosis, it doesn't matter. Everybody gets core stability. And yet on the right side of this organizational system, it's very client specific. Again, are they a tennis player? Are they a baseball player? How do we adapt the entire organizational slide to fit that person and their individual needs as a human and as an athlete? So on the left, we have structural diagnoses. So it's very important to, I think, identify a structural diagnosis for any type of a problem, and know that there's many structural diagnoses that might fit into a functional diagnosis. So for example, scapular dyskinesis might be a functional diagnosis, but we know there's lots of different structural diagnoses that could cause a functional diagnosis of scapular dyskinesis. So anything like a rotator cuff tendinopathy or a biceps tendinosis or a labral tear, all of those types of things can be contributing factors to a functional diagnosis of scapular dyskinesis. So I think it's very, very important that we identify both the structural and functional diagnosis for our clients who are in pain. And then really at the foundation of it all is the biopsychosocial factors, right? We know that just because two people have the same diagnosis, the same issue, the same pain generator, the same surgeon, the same everything, they have very, very different reactions to surgery or to the rehab process. And that's what makes everybody an individual, right? And so the biopsychosocial factors, we could have an entire hour-long talk just on that kind of box alone. So I really want you to be able to sort of see where the medical model is kind of more on the left, the performance model is really more on the right. But of course, there's overlap here. And to me, the overlap is at the nervous system. That is really where both medical and performance really, really overlap. And for me, it's super, super exciting. So that's where we're going to spend our time today, again, is in that sort of somatosensory control area, or really the nervous system. So just to be clear, all the other things I talked about are just as important, right? Of course, picking up heavy things and putting them back down again. It's really important. And being able to do that with speed and being able to apply that to acceleration and having good, good kinetic linking and all of those things are super, super important. I just want to understand, that we're only focusing on this one tiny box for the next hour. So just to kind of set that expectation, I work on a lot of other things and maybe some of the things that we're going to talk about today, and just kind of want to set that expectation moving forward. So, so yeah, that's where we're going to be. So really, the somatosensory control stuff, or the nervous system stuff, is super exciting. This is where we get vision and vestibular and environmental changes, and all these different things come into play that can kind of get really, really fun. We have to be very careful that we don't turn this sort of portion of the organizational system into a circus act. We need to be able to understand. The more we understand, the more we're able to organize, and the more we're able to progress and regress our therapeutic interventions. So with all of that said, the somatosensory is obviously just sort of a big word. Keep in mind, it simply just means all of the mechanoreceptive, thermoreceptive, pain information coming from the periphery. So yeah, it's a big word for a big thing. I mean, it's all the information that is constantly coming to us from the periphery and needs to be processed by the central nervous system. I mean, that is happening at a constant pace all the time, which is pretty insane. And it's that a conscious appreciation of the somatosensory information that leads to sensations for us of pain, or being too hot or too cold, or feeling something against our skin, or hearing something from outside that catches our attention. That's all in the somatosensory system as well. So this is a really, really big topic, and it's difficult for people to grasp. It's difficult to understand because it is so broad and it's sort of intangible, right? Like, how do we touch, feel, all of these things about senses and whatever? It's much easier to touch and identify the biceps. I know that it flexes the elbow. I know how to load that for hypertrophy. I know how to do, whatever it may be. The musculoskeletal system is so much more tangible. So we like it, right? We totally like it. But the nervous system, man, this is really where it's at. So I'm super fired up to kind of talk about it. We have to understand that there is a difference between hardware and software. So, I am so not computer literate. Like, it literally took me about 5 takes before I even started to record this presentation. And so we need to understand that I am giving the computer certain commands in order to record this webinar for you. And I've got a pretty new computer because I fried my computer about 2 months back by dumping an airplane drink in my computer. So fried the entire thing, basically had to get a new computer because I messed up the hardware of the computer, right? Versus today, my computer is almost brand new. It's perfectly fine. The hardware is working fantastic. Me, the user, was putting in inappropriate commands into the computer, so I couldn't get it to do what I wanted it to do. So that latter example is more of a software issue. The commands aren't correct. So the hardware of the computer was having a hard time figuring out what I wanted to do. Like, the computer doesn't have a brain per se, right? It's going to have the output based on the input that I give it. So if I continue to give the computer the wrong input, it's going to continue to give me the wrong output. It's not a computer problem, it's a computer user problem. And those are two really different things, right? A computer problem would be a hardware problem. A computer user problem, which is me, would be a software problem. And so if every time I would try to do a webinar, I just threw the computer against the wall because I was like, oh, something's wrong with the computer. There's nothing wrong with the computer. There's something wrong with the computer user. So that's the difference between hardware and software. And we can't treat everything in the human body like a hardware issue. It's not always about a limitation in somebody's joint, or weakness in somebody's muscle, or inappropriate abilities to link because of decrease in joint range of motion, or those sorts of things. There are times when it's a hardware issue, but there's times when it's a software issue too. And we need to be able to understand and determine and work on those things moving forward in order to have good programming. So when we look at this is such an old picture. I love this picture. Lee and Gray and I were laughing about this picture because this picture is literally like 20 years old. But anyway, so we've got 2 people here. Kyle up on the top. I'm not sure who that is on the bottom, but anyway, they have pretty similar ranges of motion, right? Like, Kyle's thighs in the top picture are a little bit bigger, so maybe he's got a little bit less knee range of motion. But overall, they look pretty similar from a mobility standpoint, not totally different. But when we look at these two guys squat, they're two totally different things. Now, if we look at the picture on the left, and that's the only picture we saw, and we said to ourselves, oh gosh, like look at his, he doesn't have any ankle mobility, his knee and hip mobility is horrible, his thoracic mobility is terrible. We have to do all of these range of motion things and flexibility things and mobility things in order to get him to look more like the guy on the right. We would be wasting his time, we would be wasting our time. I mean, like 6 to 8 weeks of wasting time, right? Nobody can afford to do that, no matter what level of sports that you're working at. So no one can afford that wasted time. Not going down the path of misinterpreting a software issue, which is what he has, right? This isn't a hardware issue. He doesn't have a mobility problem. Look at him on the right. When we take gravity away and we allow him to just express his movement as is, that's not a hardware issue. That's a software issue. Once we get him up against gravity and we ask him to perform a task, he can't perform it even though he has the mobility to do it. So again, we have to be able to determine the difference between hardware and software issues when we're working with clients so we don't waste our time. We want to be nice and efficient. So let's look at the nervous system. We talk about the nervous system. It's huge. What are we talking about? Well, let's break this up into two different things. Knowing that they work together, right? I'm going to kind of talk about all of these things in piecemeal, but understand they all work together at the same time. So we've got the central nervous system and the peripheral nervous system. The central nervous system really consists of the brain and spinal cord. That is it. The peripheral nervous system is everything else. It's 31 pairs of spinal nerves and the autonomic nervous system. And we're going to talk a lot about the autonomic nervous system here. I'm just going to kind of move this picture maybe towards the bottom. That might be better for us. Sorry if I made you dizzy there on my little tour around my computer screen. But yeah, so the central nervous system is different than the peripheral nervous system. Every piece of information that comes in the periphery is going to be interpreted by the central nervous system, whether that's at the spinal cord or the brain. So we have to understand, look at those spinal nerves. We have to understand that not only do the spinal nerves innervate muscles, but they also innervate organs too. And that's going to come in really handy to know about kind of as we talk more. So as we look at the peripheral nervous system, okay, let's split this up a little bit more. We have the picture on the right is more kind of what we think of maybe when we think of the peripheral nervous system. Common peroneal nerve, deep peroneal nerves, obturator nerves, the ulnar nerve, right? All of these sort of things that we talk about, the innervate muscles, which are really easy for us to talk about. And sometimes that's as deep as we want to go into the nervous system. But we also really have to understand the parasympathetic versus the sympathetic nervous system. Those two things make up the autonomic nervous system. So again, the autonomic nervous system is part of the peripheral nervous system. And it's super, super important from a regulation standpoint. We're going to talk about this more in depth here. But the sympathetic nervous system, I think we have a slide here. Yes, exactly. So the sympathetic nervous system, this is our fight or flight. This is when we are ready to fight or flee, right? So whether you're trying to run from your predator, either way, we're in a stressful situation. Our pupils dilate because back in the day, we wanted to see our enemy, right? So if my pupils are bigger, I can see better. So my pupils dilate. I have increase in blood flow to my muscles because I'm about to use them in order to punch somebody or to run. We're ready for battle. My breathing rate increases. It gets more shallow. My heart rate increases. Everything about the sympathetic nervous system is fight or flight, as opposed to the parasympathetic nervous system, which is more feed or breed, rest and digest. This is when our heart rate is much slower. Our breathing rate decreases. We're able to sleep. We want to eat because the muscles are no longer flooded with blood. The blood is now more towards our digestive system. So we eat, we're able to digest better. We want to have sex. We want to reproduce. We're relaxed, right? Like this is the area we should be living in, is this parasympathetic nervous system. We need to tap into the sympathetic nervous system when needed. So I'm not saying that the sympathetic nervous system is bad. I'm just saying we only need it at specific times. Our set point should be in a parasympathetic state. And the sympathetic state should be reserved for states of emergencies. So again, we need to understand that that sympathetic nervous system was meant to save our life. And the parasympathetic nervous system is where we repair our damage to our cells. We decrease our over physiological stress. We just feel better. But when we tend to stay more in a sympathetic state, we don't sleep as well. If we don't sleep as well, we don't have the proper hormonal releases that come with deep sleep and REM and sort of all of those things, right? So we don't recover as well. Our immune responses are lowered. We get sick easier, right? So just think about those times when you have been going, running hard, traveling, different time zones, not sleeping well. All of a sudden now you get sick, right? Why do we get sick? Because our immune responses are lower. The sympathetic nervous system is not where we're supposed to be living, and yet how many of us live in a state of being on the right more than we do on the left, right? I know for me, I do, right? I mean, I fly 200,000 miles a year, constantly on the go, constantly on a stage, speaking in front of people, or coaching hundreds of participants, or working with athletes and giving them my energy. It's go, 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 right? And now, especially now, everyone's like, oh, we're all staying at home. It should be nice and relaxed. I feel like I'm working harder right now than I ever have. Nothing about this stay-at-home order or quarantine is relaxing for me. I'm on my computer now more than ever. It's so hard to shut down, right? So it's like we've just spent the last how many years telling our clients to get off their computer and to get off of their phone. And now that's the only way we're able to interact with each other. So it's just our entire lives. We're driven towards a sympathetic state. And it's a problem, man. It is a problem on a lot of levels. So to just kind of realize that, neither system is good or bad. We need both systems at different times, depending on what is going on, right? And this is why, I've been doing a lot of studying of Chinese medicine and kind of just looking back to the root of a lot of things. And that's why I love the yin and yang symbol, because, you can't have one without the other. And then that little white dot and that black dot, it just goes to show how intertwined the two things are. And, we have to have both. We've got to be able to go from being on and off. But the problem is maybe we're not used to being off. And we've got to be able to tap into that parasympathetic state. So don't get me wrong. I'm not trying to say that a sympathetic state is bad. It's just not needed as often as we think it is needed. So ways to tap into that parasympathetic state, right? So let's talk about yoga. So we know that yoga has a lot of different benefits, right? Everything from reducing stress to improving balance to decreasing pain, improving flexibility, right? All of the different things that are kind of listed on this slide have been shown to happen when we do yoga. So why is that, right? Like, why is yoga so quote unquote great for us? And I am going to try to move this maybe down here. I want you guys to be able to see the references so you can get more information if you want. But when we kind of start thinking about meditation and yoga and how do these things allow us to tap into the parasympathetic state, we know that yoga, oftentimes yoga is such a huge thing. I'm sure some of you practice yoga, and we can do an entire talk about that, right? So many different things that come along with yoga. One is about the asanas, right, or the postures. But there's a huge part of yoga that is about breath, right? So pranayama is an entire sort of limb of yoga that really helps to define the practice of yoga, is pranayama, or the practice of breath. And breath is often associated with meditation. Meditation is often associated with stress reduction and stress relief. So why is that, right? Why, when we start to talk about meditation being so good for us, right? How does that work? Well, we know in the literature, and here's some examples for you, that breath-based meditation has been shown to balance the autonomic nervous system, decreasing our flight or fight responses that can be associated with stress. Well, why, right? Why does breath, for me, like, I always want to know the why, right? I was that kid, like, why, right? I'm sure my mom wanted to kill me, right? But I always wanted to know why. Why was something happening? And so why does breath bring us into a more meditative state? Why does breath work help balance out the autonomic nervous system? Well, when we look at, oops, let's go back here. No, go back. All right, so when we look at, sorry guys, like I said, not the best technological person in the world. I'm going to try to just leave that in the corner, and I can always give you guys references when you need them. Just let me know. But anyway, so as we look at cranial nerve 10, so the vagus nerve, basically. The vagus nerve comes from our brain. It's the longest nerve in our body. Vagus coming from the Latin term vagrant, right? Basically, it means the wanderer. And that's exactly what the vagus nerve is. They call it the wanderer because it's so long, right? It comes from our brain and goes all the way down, travels into our neck, into our thorax, pierces the diaphragm. It doesn't innervate the diaphragm, but the phrenic nerve innervates the diaphragm, but it has to pierce the diaphragm to go into our stomach, so it can't, or into our abdominal cavity or into our peritoneum, in order to innervate our stomach and our spleen. Our kidneys are retroperitoneal, so it has to go even behind the peritoneum to get to our kidneys. Innervates our liver, our colon, right? So this thing innervates so many different things and has a huge impact on how these things work. Well, the vagus nerve is a huge parasympathetic stimulator. So it helps with digestion, helps with all of this stuff, affects our heart rate, affects our lung respiratory rate, all of these things. So because it has to pierce the diaphragm, we can stimulate the vagus nerve when we move our diaphragms in a very big, long, slow manner. So what happens when we do meditation? Meditation and yoga are often associated with breath and breath-based meditation. Breath is associated with big, long, deep diaphragmatic breathing. When we move our diaphragm, we stimulate the vagus nerve. The vagus nerve innervates all of these organs and takes us into a parasympathetic state. If we go back to anatomy, it can all be explained. This is why I'm such an anatomy nerd. And typically we have an annual dissection course that is open to anybody in order for us to understand anatomy better. I'm hoping we can run it this year. We were looking at August. But yeah, if you haven't done a dissection or had the ability to get into a cadaver and get to see what these things look like, it's really, really unbelievable. It's an unbelievable experience. If we can go back to anatomy, it can explain so much. And for me, that's really, really important. So again, let's see if I can, there we go. All right, so the vagus nerve pierces the diaphragm. So the more we can get that diaphragm to move, the more we can kind of put ourselves into that parasympathetic state. So again, we can do that with breath work, or we can do that with abdominal massage. So if you guys have maybe seen some of Jill Miller's stuff, I absolutely love her stuff. They've been doing abdominal and visceral massage from, AT Still. I teach at Andrew Taylor Still University. Andrew Taylor Still is the founder of osteopathy. And I think that's where I found the picture up on the left, right? Like visceral and abdominal massage has been around for so long. And I think Jill has done a great job with her tune-up fitness type of things in order to kind of bring some of that back to the mainstream. But we can stimulate the vagus nerve with abdominal work as well. And if you're not comfortable with this stuff, guys, I'm not asking you to go outside of your scope. I'm asking you to make friends with someone who can broaden your scope, right? So it's not about having to be an absolute jack of all trades. It's about making sure that you have a referral source and people that you can team up with in order to make sure a lot of these different things are being addressed. So not asking you to practice outside of your scope. I'm just asking you to kind of entertain that idea or entertain the thought that maybe there are some things that you can be doing with someone in your network that can kind of address some of these things. So I know it's kind of strange and you do have to have a skill when it comes to abdominal work from a digestive standpoint. So don't just start digging in on everybody's abs. But, I think Jill does a really, really great job of sort of making it very, very easy, very, very simple to learn. And yeah, definitely kind of check out some of her stuff. So that's the autonomic nervous system portion of this. The peripheral portion of this is we have to remember that our input is going to dictate our output. And I can't be arrogant enough to think that the stimulus that I introduce into the body is only going to be interpreted by the musculoskeletal system because I'm a strength coach or an orthopedic physical therapist, and that's all I care about, supposedly, is the musculoskeletal systems, right? We have to understand that every stimulus we have into the body has the potential to not only stimulate a muscle, or myotomes, right? If you do something to one muscle, we can actually increase the signal to all the muscles that are being innervated by that same muscle, right? So rotator cuff and grip strength is a great example. Why, when we work on someone's grip strength, can we get an increase in their rotator cuff activation? And it's one, it's because of stabilization, but two, it's also because those things are innervated by similar things. C5, C6 innervates the posterior cuff, innervates part of the deltoid, it innervates our wrist flexors, it innervates our finger flexors, right? So anytime I do something with my grip, I'm stimulating everything that's possibly innervated by C5, C6. So I better understand all the different muscles that innervate are innervated by nerves that come from C5, C6. So that's the myotome aspect of it. Same thing from a dermatome standpoint. What happens if I brush the skin around an area? Can I stimulate an area from that standpoint, just simply from a skin standpoint? Absolutely. We do that in rehabilitation all the time. So we need to understand our dermatomal patterns. This, I'm going to skip down to viscerotomes. Viscerotomes are knowing that, gosh, not only do I have I've got both ventral and dorsal nerve roots coming out from my spinal cord. Some of those things innervate muscles, some of those things innervate organs. So again, and I'm making this up, I'd have to look at my viscerotomes. I don't have them all memorized, but we're talking about C5, C6. What organs does that innervate, right? Does it innervate thyroid? Does it innervate parathyroid? Does it innervate esophagus? I need to be able to know that too, which is why sometimes people have some interesting visceral issues sometimes when we stimulate. And then sclerotomes are mind-boggling. I'm actually really wanting to put a presentation together about sclerotomes, because really, like when we talk about the scleroderm, which is really the connective tissue of the muscles, the connective tissue of the bone. So our bone and the periosteum have connective tissue. And so that's scleroderm, whereas sclerotomes are really more embryological. So we know, gosh, I'm reading, if you've ever read Muscles and Meridians, and or if you've read Spark in the Machine, lots of different embryological references there, right? And how the kidneys grow out of the same layer as maybe our leg. And I'm totally, again, making that up. I need to kind of organize all of that stuff in my brain. But there's reasons, and there's cells in the upper part of our body that are also found in the lower part of the body that makes no sense. Like, why would those things be there? Well, when we go back to embryology, that's why. So we can actually stimulate certain things by following embryological principles, which is really crazy. So I have to realize and understand that because I'm introducing a stimulus into the musculoskeletal system, the nervous system very well may not express that as a musculoskeletal problem. It may express it as a visceral issue, as a stimulus in a totally unrelated area of the body that might be related to embryology, or it might be related to the skin. So, we've had this concept in Eastern medicine for a long time, right? Like when we look, and this is just a super rudimentary example, I'm certainly not an expert on Chinese medicine whatsoever, but when we look at this, it's like, okay, this where the blue dot is where something called spleen 6 is, right? So it's the spleen meridian point, 0.6. And it's used for a lot of different reasons in Eastern medicine. One, this point is contraindicated in pregnancy, right? So you're not supposed to stick a needle in that area if someone's pregnant. When you read the literature, it tonifies the kidney, right? We don't even know what the word tonify means in Western medicine. It regulates urination, benefits the genitals, regulates the uterus and menstruation, and helps to alleviate pain. And we're like, well, that's stupid, right? Chinese medicine is stupid. That doesn't make any sense. Why would putting a needle behind somebody's tibia above their medial malleoli, like why would it do any of that? That's stupid, right? Well, maybe not, because as we sort of look at it, that little blue thing, so you see the big blue dot and then the bright blue line behind it, that bright blue line is the tibial nerve. Well, the tibial nerve comes off of branches from L4 to S3. Well, guess what else is innervated by those same things? The bladder and the urethra are innervated by the parasympathetic nerves of S2 to S4. The nerves to the uterus are also innervated by S2 to S4. So if I put a needle in that spot, right, because I do dry needling as a physical therapist, so if I put a needle in that spot because someone has shin splints and I'm trying to help their shin splints, but yet I stimulate that tibial nerve and they're pregnant. Would I relax the uterus, right? Would that somehow have an effect on the baby and on the uterus? And why does that impact someone's urination patterns and the kidneys? Well, that's why, right? So we're able to, in Western medicine, oftentimes reverse engineer some of these things that the Chinese medicine crew have had figured out for thousands of years. And we want to dismiss these things as if they don't mean anything or as if they're stupid. And yet when we reverse engineer a lot of this stuff, sure enough, it makes complete anatomical sense. And so I'm just asking again us to kind of think about maybe there's more to this stuff than we understand. And the more we understand the nervous system and how things are interrelated through innervations, we might be able to reverse engineer more of this stuff out and understand why people have such different responses when we're simply trying to do, some different strength and conditioning type things. So just to kind of look at, review your dermatome patterns, your myotome patterns, look at the visceral stuff, when you're messing around with thoracic spine, like, whew, there's a lot of innervations that are happening in the T-spine when it comes to organs. So things that we really need to kind of think about and look at. I think I mentioned this book earlier, Muscles and Meridians, which is just a fantastic book. Get ready for some heavy embryology. But one of the things that Philip talks about in this book is just simply the stimulation of the bottom of the foot. So think about how many of your clients, how many of your athletes have low lumbar spine pain, right? How many of them have low back pain? When we look at the bottom of the foot, the entire bottom of the foot is innervated by L4, L5, S1 and S2, right? And the majority of people with back pain have herniated discs at L5, like by far. So when we look at how do we change the input going into the lumbar spine, think about all of you watching this webinar right now. How many of you are doing core stability, however you choose to define that, are doing core stability within your strength and conditioning programs? I dare say everybody is, right? We've been preaching about core stability for the last 20 years. Why is back pain, back pain should be eradicated by now, but the fact that back pain remains almost the number one reason up until recently why people have missed work, that's an absolute issue. So we are all doing core stability in our programming. Back pain prevalence is not decreasing, and in fact, you can argue it's increasing. So what's going on? Maybe I'm not saying core stability is not important. Of course, I think it's important, and of course, I do it with my patients. But the other thing I do is I have a rock mat, right? And I have no attachments, other than I do speak for Perform Better, but they've got a great pre-made rock mat, right? Like, it's not like you have to go to the beach and find all these rocks and have arts and crafts day. Although if you're looking for something to do right now, that might be a good thing to do. But, I've got a rock mat, in my closet right now, and would use that and tell my patients, okay, this is going to be in front of your sink. Every time you're brushing your teeth, I want you to be barefoot, stimulating the bottom of your foot, because if I can change the input going into L4, L5, L5, S1, S1, S2, I can change someone's pain. And I can do that with a rock mat. I can do that with a spiky ball. I could do that with any type of stimulation to the bottom of somebody's foot. Input dictates output every single time. So start thinking about my patients with back pain. It's not just about core stability. It's about stimulating the bottom of their foot as well to see if I can get a change in their sensory stimulus into the same area. So we have to think about peripheral nerves, right? And I know this stuff is going way back for me. Gosh, I've been out of school for a really long time, but just review, right? Like our A beta fibers, our touch fibers, our A delta fibers are a pain fiber. It's the sharp fiber. When you slam your finger in the door, it's super sharp, super painful. And then over time, it gets a little dull and achy, right? So that's the C fiber pain. C fiber pain is more like, when your client tells you it hurts here, that's more C fiber. When your client tells you it hurts here, that's more A delta fiber. It's very, very localized. So these things matter because our interventions and how to manage that pain will differ based on that simple subjective alone. So again, A delta fibers transmit information about cold. And so if we have really sharp pain, no wonder we want to put ice on something, right? Forget the whole inflammatory, should we or should we not use ice thing. I'm just talking from a pure pain standpoint. When you have sharp pain, you want to put ice on it. When you have dull, achy, throbbing, tight, diffuse pain, you want to put a hot pack on it, right? And that's why, because these receptors are stimulated by different things. So again, we go back to anatomy, we go back to neurology, we go back to foundational physiology to see how these things make sense. So yes, so gamma motor neurons, muscle spindles, again, same thing. Let's kind of talk about these sorts of things. When we talk about that concept of, oh gosh, someone's upper trap is, and I've said this, I say this all the time to my clients, your upper traps are on too much. We need to shut off your upper traps. We need to turn on your lower traps, right? And so it's okay to use these types of things for client education. And I did a talk at our Perform Better One Day Summit in Austin this year about debunking our common analogies that we use with our patients. This is how I have to speak to my patient. Your upper trap is too active, your lower trap's not active enough. We need to do exercises to balance that out. We need to shut off your upper trap. We need to turn on your lower trap, and that's what we're going to do. That's fine for me to communicate that way with my client, with my patient. They need to understand it on a very, very simple level. If I ever were to tell you as a colleague, oh gosh, John, yeah, her upper traps are on too much. Lower traps aren't working. We need to do some activation of her lower traps. Like, you should look at me and be like, really, Sue? Like, that's false. So let's go back again to neurology. What's happening here? The upper trapezius is innervated by cranial nerve 11, so the spinal accessory nerve. The spinal accessory nerve innervates all of the trapezius, upper, middle, and lower. So it's neurologically impossible to fire one portion of the trapezius without firing the entire thing. So from a neurology standpoint, that analogy is debunked right out of the gate. But what happens is that different portions of that muscle go on tension. And so when that happens, hang on, I got to put my wiener dog down here. There's Richard, by the way, just so you guys can kind of say hi to him. He's nursing a back injury right now, so we're not letting him. So anyway, so when we start talking about different portions of the muscle, what happens? So think about, okay, I've got poor posture. This starts to get stretched. My gamma motor neurons, the interfusal fibers, begin to kind of feel that stretch. They send a signal to the spinal cord. The spinal cord, it tells the spinal cord, like, hey, these muscle fibers right here are getting stretched. Something's wrong. We need to contract, because these things are just going to keep stretching and get injured. That's not going to be good. So the spinal cord says, hey, I'll handle it. Don't worry. Sends a message to the extrafusal muscle fibers, or actin or myosin. Says, hey guys, I need you to contract a little bit here. Something's going on. And so we kind of have this circle. So now we get this like little contraction just in that kind of motor unit area, or in those areas that are getting stretched. So now we have portions of the muscle that are sort of getting tight and lengthened, right? And the body is trying to balance that out. And so what happens then is we begin to turn over collagen. So every, 4 to 6 weeks, 6 to 8 weeks, we have a collagen turnover in our body. And so depending on the tissue, right, every tissue is a little bit different. And so what happens over time is that now I get collagen laying down in this new shortened position, while my lower trap has collagen laid down in the new lengthened position. And now I've got a collagen problem on top of what started off as a neurological signaling issue, right? Is that making sense? So now I do have a structural hardware issue that I need to deal with, but that hardware issue started off with a software problem. So I need to deal with both the hardware issue by doing maybe some soft tissue work, right? Or maybe doing some instrument assisted work, or cupping, or whatever your favorite manual therapy treatment is, foam roll, whatever it may be, massage stick, all of those sorts of things. But then I absolutely have to follow it up with therapeutic exercise of some sort in order to activate and reposition and do neuromuscular reeducation in order to put that muscle in a new position. So again, over time, new collagen can be laid down in a new position, and I can change my structure. So this is a great example of how structure and function, hence the name of my company, interrelate, right? Is because these things go back and forth all the time. But when we say to our clients over and over again, the upper trap is on, the lower trap is off, we need to shut off the upper trap and turn on the lower trap, we begin to believe these things, right? Like I said these things for a decade, and I totally forgot the fundamental physiology and neurology behind what's really happening. So I think if we want to really continue to elevate our profession of strength and conditioning coaches, we've got to continue to look at and talk this way with each other and really sort of challenge each other to go back to foundational neurology, physiology, and anatomy. So again, the better we understand these things, the better our programming can be, which I think is really, really exciting. So these slides basically just say everything I just said. So now let's kind of look at it from a pain perspective. We've already talked about this, how A delta fibers are fast, very, very localized, very, very sharp. C fibers are more slow. Dull, diffuse pain kind of happens a little bit later. The thing with the brain and pain is that there is no pain center in the brain. When someone has pain, this is one fMRI study that shows all the different areas that it gets lit up when somebody is in pain, right? That's really scary. That's why pain is super complicated. Excuse me, that's why pain is super complicated, because all of these things get stimulated. One of my favorite memes of all time, right? Pain is about meaning. So because it doesn't stimulate one area of the brain, because it is stimulating so many different areas and gets really, really complicated, we have to understand that pain means different things to different people. So when we want to intervene for someone who has pain, from a nervous system standpoint, we have to understand that it's an extremely individual experience, and not all two pain perceptions are created equal between people. So let's look at a little bit of literature on motor adaptations and how pain can affect our programming. So this is just one study. Paul Hodges was a part of it. Francois Hug, and Hug or Hugh, I'm not sure exactly how to say it, but really, like, how does the cost of using the non-painful limb matter in a painful situation? So basically what they did was they looked at 35 subjects, and all they did was ankle plantar flexion. So they did ankle plantar flexion, and then they injected saline into the soleus to create a painful stimulus, which that is actually super painful. And so then they asked them to do plantar flexion again and to kind of see what happens. So basically what happened was when there was no pain, right, the force through ankle plantar flexion was created equal between both limbs. And when you injected a painful stimulus, let's say into the left soleus, what happened was the person was still able to output the same amount of force. It's just that they transferred the force to the non-painful limb. So basically the person compensated, right? We see that all the time. When someone's in pain and we ask them to do a bilateral movement, they of course naturally compensate. They remove weight from that limb and the other side has to make up for it. So we see that all the time. In the presence of pain, the body's going to reduce the force on the injured limb, shifting more load to the non-painful limb in an attempt to decrease pain or preserve the injured limb. It is the nervous system's priority to protect injured tissue. So if you have a tendinopathy, a tendinosis, a torn ligament, a strained muscle, it's the nervous system's priority to protect that and to alter your movement patterns in order to protect that tissue. So as interventionists, we have to be able to understand that and know that the body's going to do that. So if I'm prescribing bilateral exercises to somebody who is in pain, they are of course going to compensate no matter how much I try to coach or cue them to not. So pain absolutely influences my programming. And I absolutely will give unilateral exercises in order to not allow them to compensate in a bilateral movement pattern. So again, the protection of painful tissue is prioritized by the nervous system. We know that. So in terms of load, if you give them a bilateral exercise, they're automatically going to decrease the load. This is just more of exactly the same. So now here's another example of creating a painful situation. 15 healthy subjects performing 3 tasks. They had them perform a knee extension, so just a single joint exercise, a single leg squat, and a bilateral squat. And they did the same thing to the quad under non-painful conditions. They injected the saline and looked at the into the vastus medialis, and then they did it again 3 minutes after their pain was gone 100%. And so they looked at force data and they looked at EMG. So sure enough, basically what it showed was that, again, if someone has the opportunity to cheat, they will take it. So if you gave somebody a task with more degrees of freedom, so think about in a bilateral squat, someone's going to move both ankles, both knees, both hips, right? We'll just say 6. If you give them a single leg squat, they only have the ability to move one ankle, one knee, one hip. So we just went from 6 degrees of freedom of motion to 3 degrees of freedom of motion. If you give them a knee extension exercise, that's 1 degree of freedom of movement at the knee, right? So we just went from 6 degrees of freedom to 3 to 1. The more degrees of freedom you give your person, the more opportunities they have to compensate. So the more complicated movement pattern you give somebody, just the more areas that they're going to compensate in. And what this showed was that nobody compensated in the exact same way. People compensated differently. But the more degrees of freedom that you gave somebody, the more opportunity they had to cheat. So if you don't want them to cheat, you need to give them less degrees of freedom to cheat through. So for me, if I have somebody, let's say somebody's in pain, but they don't have any inflammation, they don't have any nociceptive stimulation anymore, there's no neuropathic pain, so I know there's no injury to the nerve, but they're still processing a pain sensation in their brain, right? Like they're telling you that it's painful, even though we know that structurally there's not an issue there anymore. This happens all the time, right? We call that chronic pain at times. We're trying to call that a little bit more like nociplastic pain in the literature. You'll kind of see that where the central nervous system is misinterpreting pain responses. So we see that all the time, right? Where people are in pain, but there's no offending stimulus anymore for them to still be in pain. Well, those are people that I want to force to use the injured area because I want them to understand that we're not going to make their situation any worse. So maybe with those people, I want to select lower degrees of freedom of movement. So maybe I do want to select a very isolated movement pattern to force them to use that joint and make them realize, okay, we're doing a knee extension exercise here. Your knee's not blowing up with swelling. There's no redness. There's no heat. There's no signs of inflammation. We haven't done anything to create nociceptive issues here. Like, we're okay. Okay, great. Now I can slowly increase degrees of freedom and increase to more complicated movement patterns, but maybe I need to start really, really isolated for that person in that situation. So I think that we can't really just be like, oh, only single, unilateral exercises when we're talking about people in pain. I think we have to figure out, okay, what's happening with the nervous system? What's my appropriate intervention? Do I want to use more or less degrees of freedom? Do I not want to allow them to compensate? I probably don't. So I need to select exercises and programs that are going to have the output that I want. And the more I understand the nervous system and the more I understand how the body processes pain and how pain impacts people's movement, the better off my programming is going to be. So basically that also says that. But then I found a study, which I thought was really interesting, from 2016, that actually showed when you had an acute painful stimulus, so like capsaicin-induced pain, right, where someone put hot sauce on. I worked in Major League Baseball for 6 years. I mean, guys would always put hot sauces, right, like all over their arm. They'd have their special mixes. Like, why did guys do that? Well, because when you acutely stimulate something like that with capsaicin or these thermogenic kind of things that like people put on their skin, they do have a better awareness of where their body is in space because they're tuned into it. So the nervous system can tune into pain, which can sometimes be a good thing. It actually showed in the study that motor learning actually occurred better when people were in an acute situation. So I'm not saying like go put, some type of hot sauce on your patient's skin and then have them learn a new task because it's been shown that they're going to have better motor learning. But it's something to kind of think about and consider, and just sort of made me like have an aha moment of why my baseball guys liked to use so many hot sauces, is because they actually did have a better awareness of where they were in space. And so, when we're talking about skill acquisition, that's kind of an interesting thing to sort of think about when people say like, oh, can I use an icy hot or a biofreeze or something like that? Well, there's pros and cons to that from a lot of different things. But if we're talking about motor learning, the evidence is sort of showing us that, it might be a good idea if you're trying to have them learn a new skill. So, if my patient who is in pain wants to use a topical like that and then exercise, I'm totally fine with that because they're probably totally tuned into what we're trying to do. And the evidence is showing that there's some decent motor learning happening. So kind of interesting there. So again, injury is going to reduce our functional variability in the system. So if we think about in the examples that I gave before, between a double squat, a single leg squat, and a single leg, just a knee joint extension, how we decrease the degrees of freedom there. Well, injury also decreases our degrees of freedom. So if you think about putting your elbow in a cast, if you broke your elbow and your elbow was in a cast and you needed to do something, well, that elbow is not able to do anything. So you would have to compensate at the shoulder, at the neck, at the wrist and hand in order to complete a movement pattern. So yeah, just kind of recognizing that injury reduces the degrees of freedom that an organism has. And that if true injury is present, I'm going to probably select a unilateral exercise on the opposite side so they don't continue to offend and irritate that injured tissue, because the nervous system is going to prioritize the health of that tissue. If an injury is not present, then maybe I want to choose an exercise with less degrees of freedom on that side in order to kind of have my client utilize that area. So again, thinking about neurology, pain processing, how the body processes pain in order to affect our programming. So kind of getting close here to the end, this concept of functional training for me, I love these. It's like, oh, she doesn't have shoes on, so all of a sudden it's functional. But this concept of functional training, like, what is functional training? That term makes me crazy. And let's try to really define it, right? Like, what does that mean? It's not about having perfect movement. It's about having motor redundancy. So as we're sitting here, I know we all can't see each other, but as you're watching this video, I want you to just go ahead and touch your finger to your nose. Like, seriously, go ahead and do it. Just touch your finger to your nose. Just take a second and do that. Awesome. Okay. So most of you probably used your dominant hand. Maybe some of you, if you're taking notes, you use your non-dominant hand, but none of you probably did this, right? Like, that's still following the directions. That's touching my finger to my nose, but it's not the most efficient way for the nervous system to complete the movement pattern. The most efficient way for the nervous system to complete the movement pattern is to move one joint toward your nose, right? And now think about, again, if you had that broken elbow and your elbow was in the cast and I gave you that command, what would you do? You would either use the opposite hand, or you would bend down or try to figure out how to get your face towards your finger. So it's not about having perfect movement. Movement is going to be dictated by the degrees of freedom or the health of the organism, which means it's not about, for us as coaches, it's not about us coaching perfect movement patterns. It's about coaching motor redundancy. It's about exposing my client to as many different movement patterns as possible so they can choose the movement pattern and the range of motion that's necessary to complete a movement task in any given environment, depending on what they encounter. Because at the end of the day, that's what's going to happen. The nervous system is going to select the most appropriate movement pattern to complete a task given the environment it's being asked to perform it in. So when we look at this concept of dynamic systems theory, that's really what it comes down to, and what they talk about is the dynamic systems theory. And I'm going to try to move this. Oh, no, let me go back here. Here we go. Give you guys some of those references there. Dynamic systems theory is really about creating functional variability in the system. So the health of the organism, right? We already talked about that. Injury limits the degrees of freedom of the organism, which is going to limit how much or how I complete the movement pattern. So that's the organism. Organism is the human. The task being performed is going to change based on also the environment in which it's being performed in. So think about like, a few years ago, the Boston Marathon was being ran, and it was in a very extreme cold situation. So chilly. People were being treated for hypothermia. People were dropping out of their race. The person who I think won that year was like 15 or 20 minutes over her time. Like, it was the same organism, right? So the same person who had trained for the marathon, it was the same 26 point something ridiculous miles. But what had changed was the environment, and the environment, right? The change in temperature dictated how people executed the motor pattern. So it wasn't about the person. It wasn't about the task. It was about the environment it was being performed in. So again, it's not about coaching perfect movement. It's not about teaching perfect movement. It's not about making sure that my athlete can squat with her toes forward or her knees directly over whatever. I'm not saying those things are wrong. I'm just saying there's more than one way to complete a squat. And so really, as a strength coach, it's my job to expose my client and my athlete to as many possibilities as possible so the nervous system can select the most appropriate way to complete a task based on the environment it's being asked to perform the task in. That's about creating functional variability. That's about creating motor redundancy. That's functional training. And that's really where we should be. And that's really difficult, right? So we know that motor patterns can be performed in a variety of ways. Injury reduces that functional variability. That's why injury is a problem. It reduces the opportunities for the organism to complete a task. So again, we always want to have as many options as possible to complete a movement pattern. And I relate it back to baseball or to any team, right? Football, it doesn't matter. Like when I was with the baseball team, we had 25 guys on the roster. Our manager was a lot happier when he could field a team with 25 guys to choose from. When we had 5 guys on the DL or unavailable because they were hurt that night and he had to field a baseball team with 20 people, he was not as happy, right? More options give us more choice based on the situation that comes up. And so a baseball game or a movement pattern are no different. If my organism, if my body has more ways to complete a movement, my body is happier because then I can complete that movement task in any situation, no matter what the temperature, no matter what the light, no matter what anything is. So we kind of always have to remember it's not just about the task, right? We like as coaches to manipulate the task. We're going to squat, we're going to front squat, we're going to back squat, we're going to single leg squat, we're going to pistol squat, we're going to split squat. All of these different things sort of alter the task. How do we alter the organism, right? If I go back here, how do we alter the organism, right? We can alter the organism by changing their vision, by changing the position of their head, right? How many times do we coach acceleration or linear speed and someone's looking straight ahead, and yet when they're on the football field, they're looking behind them, trying to see where the ball is going to be. Their head is spinning all over the place, so they're altering their vestibular system, right? They're not looking straight ahead. So how do we manipulate vision, the vestibular system, while people are doing different movement patterns? That's really important in task or in organism manipulation. When we talk about environmental manipulation, right? You guys have kind of seen I'm in my office, right? Obviously I have windows, the lights are going up and down. So, we can alter light. Now, of course, we can't change the position of the sun, but we can take people outside. We can use sunglasses. We can have no sunglasses. We can have music, right? Think about how different your workout is when you have like your absolute favorite jam on versus like when you're forced to listen to music that you cannot stand. It's like you can't wait for that workout to get over, right? Like, why does music motivate us to have a great workout or not? You do not want to try to do a max lift when you've got classical music on or some type of music that you hate, right? Like if you're going for a max lift, you want your absolute best jam on the radio because what we hear affects our motor output, right? It shouldn't matter, but it absolutely does. So environmental manipulations through light and through sound make a huge difference. And so as we're programming, I want you guys to begin to think about, how do we manipulate for some of these things like organism and like environment, and not do it in like a circus kind of way, right? Because unfortunately, it can turn into a circus act, right? This is where we see it on social media all the time, right? When people are on a balance pad and things are being thrown at them and the lights are off and the music is blaring. It's like, oh gosh, it can turn into a three-ring circus pretty quickly. So I challenge you guys to think about, just like we progress and regress our tasks, how can we progress or regress the organism? How can we progress and regress the environment? There's times from an environmental standpoint, when I think about the organism and how I manipulate that, task challenges, listening challenges, cognitive challenges, right? Like every time, sometimes you have those athletes where I am super chatty Cathy with them on a Monday, and every time I ask them a question, they have to stop working out, they answer me a question, then they go back to working out, right? Well, that's a problem because especially if you're an athlete in sport, you've got to be cogniting a lot of different things. You're trying to execute the play, reading the field, what's going on, right? Like you can't just be focused on your movement pattern. And if your movement pattern messes up because I'm asking you a question, that's a problem. And then there's other athletes who that's the only way they can process, right? They need a lot of stimulation because again, they're super sympathetically stimulated, that if I don't speak to them, they're super uncomfortable, right? So it's kind of like one of those things where it's like Monday, I might be really chatty with my client because, hey, what'd you do all weekend, right? And I'm talking their ear off. But maybe Wednesdays or Thursdays, I don't really say much to them. I just kind of have silence, right? But I program that. They just think, oh, Sue's in a great mood today, or Sue's really talkative, or Sue's not in a talkative mood. They don't know that I'm manipulating their ability to cognate and manipulating doing an organism progression or regression. It's not really, it's a little bit less progression and regression even when we talk about those things, but it is different, right? So think about how can you structurally and organizationally in a very systematic manner program for some of these things when it comes to cognition, motivation, vision, vestibular, environment, that sort of thing. So it doesn't turn into a three-ring circus. So yeah, that's pretty much it. I mean, ultimately, if we can understand the anatomy of the nervous system, understand the different parts of it, that's going to be really important. Understand how the nervous system affects the musculoskeletal system, especially with people in pain, and understand that it's really not about coaching perfect movement. It's about creating motor redundancy and functional variability for our clients. That's really what it's about. Practice doesn't necessarily make perfect. Being able to move into and out of all of these different motor patterns is really sort of what it's about. So maybe just kind of a different way to be thinking about things, to be dipping your toe into the nervous system, somatosensory sort of area, and just recognize that this is definitely a box that needs to be addressed in the organizational system as we bridge the gap from rehab to performance of an athlete coming back from table to field when they're in pain and they're moving towards performance. So hopefully we got you guys thinking. This is how you can keep in touch with me. You know, that is the book there. Down here at the bottom, we just launched our online education program, which is super exciting. You know, in the past when we only taught dry needling, unfortunately strength coaches can't dry needle, so we didn't really have education for you guys, but now we do on our online education program, which is awesome. We have an online class that goes into a little bit more detail from this on what we talked about. It's called Chapter 7. And we're giving you guys $20 off an annual membership. If you just use that code, go to structureandfunction.net. On top of it, there's an online button there. You don't have to type in all of that. You should be able to find your way. But yeah, we're super excited to be able to bring more of these topics, more of these concepts to our online education program and to just be able to engage with my strength and conditioning community more. I am definitely a strength coach at heart and love that aspect of the rehab to performance continuum. So I miss you guys. I am so sad that we're not able to get together live, but really, really grateful that we've had the opportunity to still present the information. I am available for questions and looking forward to interacting with you guys in person, online, anytime, very, very soon. I hope everybody is staying safe and healthy and looking forward to connecting. Thanks so much, you guys.